The ELOQUENT study, which was a study in the relapse setting for multiple myeloma, compared Revlimid dexamethasone to Elotuzumab Revlimid dexamethasone, and showed a significant improvement in progression-free survival at 1 year, 2 years, and 3 years. And what the trial was looking at was in patients that were not very heavily pretreated, of which less than 20% of them had previously been treated with Revlimid, and compared the treatment of these outcomes in these both arms. And I think what this is showing, specifically with regard to the 3-drug combination, is that clearly there is a better response. And I think this better response can be potentially explained by a few things. One is that it's not only targeting the tumor cell directly through its interaction with its target, which is SLAM-F7, on the tumor cell, but potentially also on the NK cells, which also have the SLAM-F7, that interestingly can translate into an augmentation of an NK response. But also, and I think when you compare the single agent to triple agent efficacy of Elotuzumab, the reality is that lenalidomide or Revlimid is being used as an immunomodulator that is also potentiating this response. And so I think taken together, we're seeing a specific tumor-targeted therapy and benefit, and an immune benefit that is being induced both by the use of the monoclonal antibody as well as by the IMiD that is being used.
Daratumumab is approved as a monotherapy currently based on a single-arm phase 2 study. So Daratumumab is approved in relapsed refractory myeloma in patients who've either had more than 3 lines of prior therapy, including an IMiD and a proteasome inhibitor, or patients who are dual refractory to both the combination of an IMiD and a proteasome inhibitor. So it's currently approved in that relapsed refractory setting for patients who've seen most of our current therapeutics. And it's based on a single-arm phase 2 study called the SIRA study, and approximately 100 patients are treated on this, and there was about a 30% response rate in these patients who had progressed after a prior IMiD or a proteasome inhibitor. And that's where the data is approved currently. However, I think this is a very rapidly evolving space, and we'll see that use of Daratumumab be rapidly moving into the earlier lines of therapy. And exciting, we'll see here at ASCO the results of the CASTOR study, which is a randomized phase 3 study which looked at bortezomib and dexamethasone plus or minus Daratumumab in patients with 1 to 3 lines of prior therapy. So as you'll see at ASCO, you'll see the results of the CASTOR study, which looked at a phase 3 study of bortezomib and dexamethasone plus or minus Daratumumab in patients with relapsed myeloma. And so far, the hazard ratio is 0.39, and we'll see the rest of the results at ASCO. But I think that's very exciting data, demonstrating the benefit of Daratumumab in patients with earlier lines of therapy. And importantly, at EHA, we'll see the results of the POLLUX study, again looking at a phase 3 study of lenalidomide and dexamethasone plus or minus Daratumumab, with, again, very similar hazard ratio of 0.39. So I think that even though it's currently approved as a single-agent monotherapy in patients who've had multiple lines of prior therapy and refractory to IMiDs and proteasome inhibitors, I think in the very near future, as it's a very rapidly evolving field, you're going to see that moving up into earlier lines of therapy as well. So I think that that's exciting news for our patients, an exciting opportunity and option for our treating physicians. One of the important things when you start administering these monoclonal antibodies, either Daratumumab or Elotuzumab, is to really understand the infusion-related reactions that you can anticipate, your patients can anticipate, and your nurses can anticipate. And importantly, when you think about, for example, Daratumumab, there are lots of infusion reactions that you can potentially see in the first infusion reaction. So this is similar to our experience that we saw with rituximab, where it can be really prolonged infusions, times that we see due to the infusion reactions that we see. So oftentimes we'll do lots of pre-medications for these patients with Tylenol and Benadryl and H2 blockers, things that we'll typically use in Rituxan that we're all comfortable with. However, what we'll typically see is that with a second or third or subsequent infusions of Daratumumab, it becomes better and better tolerated. So those infusion reactions really diminish, and there'll be minimal infusion reactions that you'll see subsequently, similar again to our previous known experience with rituximab. However, it's very important to really understand that you can see significant infusion reactions in these patients getting Daratumumab for the first several infusions. And that's important for our patients to know, to allocate that amount of time. And these things can take up to 8 to 12 hours to infuse, for example. And it's important for our nurses to know this as well, so when we start scheduling infusion times, and not to schedule them later in the day, but first thing in the morning. And in fact, we've also seen that sometimes patients need to be hospitalized for their first infusion reaction or separate out over 2 days. And so those are anecdotes that we've seen as well, but it's important, I think, really to highlight the fact that the first infusion of Daratumumab can be prolonged with significant infusion reactions. It's important to pre-medicate these patients. However, the subsequent infusions become much better tolerated, though they're still rather long. This is actually an interesting comparison to Elotuzumab, where actually we see, though it's also a monoclonal antibody, very few infusion reactions with Elotuzumab. So though you may see more in the first infusion, subsequently, really we're seeing very few infusion reactions. And importantly, now we've gotten down to Elotuzumab being infused over 2 hours, or a very rapid infusion. And I think that's very important for our patients, both for patients as well as nurses and scheduling chair times, and for physicians as we schedule for patients. But I think that's important. The differences in the infusion reactions, I think the better prepared that we are, the better we can manage these. And I think that's very important for patients to understand that as well.